In August 2021, I was appointed to the position of Senior Authorising Officer, responsible for the establishment of the Restrictive Practices Authorisation Scheme in South Australia. I came into this work with two broad imperatives. The first was a clear direction from the South Australian Government, from the Minister and the Chief Executive, that this scheme was about being a strong safety net for people with disability. My team and I had absolute clarity about what was expected of us, that this scheme was about holding the system to the highest standards, about creating visibility, accountability, and transparency, because people with disability deserve no less. At the same time, the disability sector was also very clear in what it needed. It wanted a scheme that harnessed the ability of high quality practice to change lives. They wanted a scheme that valued human relationships and a statutory office that reflected what it feels like to sit with a person with disability, a child, a parent, a staff member when they were scared, alone, angry and distressed, because that's what the work looks like every day. The sector was asking for a regulator who would support them to do their work well, because people with disability deserve no less. So the Restrictive Practices Authorisation Scheme was born of these two different perspectives, but the same shared goal to provide people with disability with every opportunity to live their best life, without restraint and without restriction. This task seemed like an immense task then, and in many ways it still is. But what we knew was that we already had the three key ideas that we needed to create this scheme. And these will be three ideas that are very familiar to any practitioner, because they aren't new ideas. They've been around for 20 to 60 years. What is different is the way that the Restrictive Practices Unit have combined these ideas to shape our regulatory approach. The first key idea is parallel processes. Social workers and psychologists, counsellors and therapists will be very familiar with how this concept plays out in therapeutic relationships. It's where the client may project their experiences and ways of interacting in their social relationships onto their clinician. The clinician may then respond in ways that reinforce these thoughts and patterns of behaviours. The clinician then takes on some of these patterns of thinking and responses in their clinical supervision with their supervisor. This process of transference and countertransference is a common understanding of parallel processes, and it plays out between the client and the clinician and their supervisor. But these dynamics don't just occur at an individual level. Parallel processes occur when two or more systems that have significant relationships interact with one another. Whether these consist of individuals, groups, or organisations, over time they tend to develop similar behaviours, dynamics, and ways of responding. They start to mirror each other. The concept of parallel processes has been around since the 1950s. So how do we use it? The key lies in our core functions of behaviour support and behaviour change. Your role is to provide behaviour supports for people with disabilities so that unsafe and complex behaviours don't get in the way of them leading great lives. Our role is to provide behaviour support to NDIS providers, practitioners and professionals so that you can use your skills and expertise to support people with disabilities. Our role is a parallel process of your role. You change and support behaviours at an individual level. We change and support behaviours at an organisational level across the state. This very simple idea shaped the way the Restrictive Practices Unit operates, because we would always ask, what does best practice tell us about behaviour intervention at an individual level? What is the parallel process at an organisational level, and how do we do that? I'd like to say that we were being original in this approach, but unfortunately we were not. We were standing on the shoulders of giants, and there is no greater giant applying this model than Dr. Sandra Bloom. Sandra Bloom led us to our second key idea, trauma-organised systems. Sandra Bloom's research on parallel processes and trauma-organised systems culminated in the development of the sanctuary model, which has been widely adopted in child protection systems worldwide. The model is often discussed in the context of helping organisations to understand the impact of client trauma and to strengthen organisations so that they can be more responsive and provide trauma-informed care to their clients. And you may think that this is a pretty good outcome. And this is the part that most people are familiar with. But it's only the beginning. The most fascinating part is what happens next. Before I talk about that, I'm going to take a step back and give us all a refresher course on trauma. There are many definitions of trauma. I like this one from Bruce Perry. Trauma is the emotional, psychological, and physiological impact of heightened stress from experiences of threat, violence, and life-changing events that overwhelm a person's capacity to cope. The seminal Adverse Childhood Experiences study was first published in 1998, and it consolidated what practitioners had known or suspected for years, which is that the effects of adverse childhood experiences could be lifelong across health, mental health, and social domains. The work of Bruce Perry, Bessel van der Kolk, Dan Siegel, and others has demonstrated how trauma experienced during childhood can have profound effects on brain development, interpersonal relationships throughout childhood and well into adulthood. The signs of trauma may manifest as behavioural issues, developmental delays, anxiety, withdrawal, and emotional dysregulation. Trauma can disrupt the formation of secure attachments, impair cognitive abilities, and hinder emotional well-being, leading to difficulties in academic performance, social interactions, and overall functioning. You know all about this because you see these signs every day. The team and I read about these behaviours every day, the hypervigilance and the anxiety, the fight, flight, or freeze responses, people being overwhelmed by their emotional or sensory responses, people who struggle to form trusting relationships, people who have poor working memory, who find it hard to learn new information, who aren't able to pick up on important cues, and the people who reenact the same unsafe behaviours over and over again. People with disability may also experience an intersection between their disabilities and their trauma experiences, which may add further complexity when the signs of trauma are misunderstood as being functions of a person's disability or vice versa. A trauma-informed lens moves us away from a model that presumes that people are just making bad choices or are choosing to be violent or aggressive or act out. It recognises that these responses are neurological and biological responses that kept that person safe against actual or perceived dangers. It was the most logical thing for them to do in their circumstances, and they've maintained these behaviours even when the threat is no longer there, even when it is no longer the most logical response. Sandra Bloom's work builds on this individual level understanding of trauma to posit that organisations are living systems that experience chronic stress and adversity in the same way that individuals do, and can experience trauma in the same way as individuals do. This is particularly true of human service organisations. So organisational trauma occurs when the system is overwhelmed and is not able to cope. This is the parallel process. Organisational trauma can stem from the psychological and physical harm experienced by staff in their interactions with clients. This can include vicarious trauma through prolonged exposure to the traumatic experiences of clients, working in high-stress environments without adequate supports, or encountering challenging and unsafe behaviours from clients. These experiences can have a profound impact on the organisation as a whole, not just the employees within it. Organisations can experience trauma through significant public inquiries, royal commissions, and media scrutiny, through constant changes to organisational leadership and relentless workloads. These are the traumas that may overwhelm an organisation, but we often don't think of them as such. We think of them as workload issues, or HR issues, or governance issues. But trauma is the impact of heightened stress that overwhelms the system's ability to cope. Dr. Eileen Munro has researched the organisational responses to public child death reviews since the death of Maria Colwell in the 1970s, and the responses that she describes are very much those identified by Sandra Bloom in her research on organisational trauma. Organisational trauma can lead to decreased morale, increased staff turnover, decreased productivity, and create a work culture that is characterised by distrust, fear, and burnout. Trauma within organisations can compromise employee well-being, disrupt communication, hinder collaboration and innovation, and ultimately affect the success of the organisation. Chronically stressed and traumatised systems, like individuals, can have a reduced capacity for problem solving. They can be intolerant of dissent or difference, they tend towards authoritarianism, and they lean on hierarchies. So when we think about the signs of trauma in individuals and we apply it to traumatised organisations, this is what it might look like. Does this look familiar? Think about the disability services sector, but also other human services that can experience the same organisational trauma. Mental health, corrections, child protection, public health, aged care. Can you see the organisational fight, flight or freeze responses? Can you see the cognitive rigidity in the lack of willingness to share power, the constant requirement for more procedures, and the punitive responses? Can you see the us and them? Can you see the inability to take in new information or change practices? You might be saying, but Trin, I work in a human service organisation and I'm not traumatised. I feel fine. And this may be true, but organisations may embed traumatised responses over time, even if individual staff are not traumatised. This becomes the culture of the organisation. It becomes the way that the organisation does business. So now we have two ideas working in tandem. The trauma that overwhelms an individual's capacity to cope may have a parallel process in trauma that overwhelms an organisation's ability to cope, and that the same challenging behaviours that may manifest in a traumatised person may have a parallel process in the behaviours of a traumatised organisation, and the organisational behaviours that could be seen to be non-compliance, resistance, carelessness, or punitive responses may also be the behaviours of a system that is overwhelmed and not able to cope. If this is true, how do we create behaviour change in individuals? And how do we create a parallel process of behaviour change in organisations? The answer is positive behaviour support. I'm going to give everyone a 5-minute recap on the last 35 years worth of thinking on positive behaviour support. And it will be very simplistic, but I want to lay the foundation of our shared understanding. Positive behaviour support, or PBS, is a framework for thinking about and supporting behaviour that is based on a focus on human rights and quality of life for all people. These are the rights that are found in the smallest places and on our doorstep. The right to live without restriction and restraint, the right to self-determination and agency, the life outcomes that we want for ourselves and our loved ones and our communities. They must be the life outcomes that we want for all people with disability. PBS involves the use of theory and evidence to help us understand human behaviours, our needs and our experiences. While applied behaviour analysis is one key theoretical base for PBS, so are trauma-informed practices, cultural understanding, social learning, and a range of other theories that we draw from. These are the models of behaviour that not only help us to understand behaviour, but to respond to it effectively. It is multi-professional and cross-disciplinary. PBS has a systemic approach to high-quality supports and interventions that are based on formal assessment, evidence-informed decisions, personalised supports, ongoing implementation, monitoring and evaluation. It is a highly structured approach. Over the years, PBS has been criticised for not being tough enough on bad behaviour, the assumption being that PBS is about being positive about any behaviour. But this fundamentally misunderstands PBS. The outcomes of PBS have at times been described as mixed, when what might be more accurate is that limited implementation of PBS results in mixed outcomes. When we look at George Sagai and Rob Horner's conceptualisation of whole of systems positive behaviour support, we get a very different understanding. People may be familiar with the PBS triangle, and it is a concept that is found across public health models worldwide. In systems-wide PBS, the strategies are applied across the entire population. So for the vast majority of the population in our system, 75 to 85% of the population will have no behaviours of concern. Tier 1 or universal supports will be sufficient to help them succeed. These strategies are clear behavioural expectations, inclusive environments that foster expected behaviours, active supervision and monitoring, teaching expected skills and behaviours, firm and fair redirection, and systems-wide recognition and positive reinforcement. These are the things that should be in place for everyone. For some of the population, 15 to 20% will have some behaviours that may get in the way of them living a great life. The Tier 2 strategies will help this group. This includes some targeted skills development, increased monitoring and support, differential reinforcement of the behaviours that we want to increase compared to the behaviours that we want to get rid of. For a small part of the population, 3 to 5% may have complex and challenging behaviours that are of a frequency, severity and duration that are unsafe for that person and the people around them. For this group, Tier 3 strategies involve intensive individualised supports, case management across disciplines and services, and the management of risk and safety that might involve a restrictive practice. The most recent NDIS Commission quarterly performance report for October to December last year found that nationally, 2.2% of the NDIS population was associated with a regulated restrictive practice notification. In South Australia, this was 2.9%, an increase from 2.6% a year earlier. Do we have more restrictive practices in South Australia, or are we seeing the person and seeing the practice that the research tells us we would expect to see at a population level? What must be highlighted here is that currently in the NDIS, we do not have systems-wide PBS. What we have is a focus on the Tier 3 cohort, and they have proactive and universal supports, targeted supports to redirect and divert concerning behaviours, and intensive strategies that may include restrictive practices. But in a systems-wide PBS approach, I should be able to walk into any supported independent living accommodation or residential care setting and see Tier 1 universal strategies in place regardless of whether or not anyone in that setting has challenging behaviours. I should be able to have clear visual and environmental cues that help me to predict what will happen in the day, let me know who is around me and how I can get help if I need it. I should know what behaviour is expected of me and get clear feedback and fair and firm redirection if I misunderstand. I should get recognition when I'm doing the right thing and have my experiences validated. But this is not always the case. Sometimes these universal strategies that should be in place for all people in all settings are only in place when somebody has concerning behaviours. But these are strategies that work really well even if you don't have behaviours of concern. This very individualised level of intervention and this very individualised application of PBS has a number of consequences, not the least of which is that it increases the proportion of people who are likely to be in your Tier 3 cohort. Brent Haywood has highlighted that the focus on individual level data and practices minimises the systems-wide organisational elements of PBS that are fundamental to its effectiveness. So now that we have a foundational understanding of systems-wide PBS across a large population, let's bring that together with the concept of parallel processes. Our approach to regulating restrictive practices across a continuum of behaviours and across levels of compliance starts to look like this. Rather than focusing just on the pointy end or focusing on non-compliance, we see the system as a whole. We see the entirety of the 235 NDIS providers that are currently registered with the authorisation scheme in South Australia. And when we see the breadth of the population, when we look at the system as a whole, the majority of the system does not show behaviours of concern that create a risk of harm. The majority of the system is trying to follow the rules and do the right thing. Some in our system are our champions. They have strong and rigorous arrangements to promote best practice. They are the organisations that have clear policies that are followed, good quality assurance and quality control, line of sight over their data, consistent training and professional development, strong clinical governance, and partnerships with their clients. We recognise and reward these organisations by showcasing their work and bringing them in to collaborate with us on new initiatives. Many in the system are compliant. They will do their best to follow the rules and will do so if the rules are clear, available, and easy to follow. We engage this cohort through our frequent communiques and our systems-wide audits. We provide dashboards for monitoring and alerts and continue to update our online resources on our website. We engage with them Monday to Friday, 9 to 5 on our duty service. Some in the system are confused and some are careless. They may get things wrong because of this confusion and this carelessness. They are not compliant and this is not okay. We enable their compliance by providing targeted education and skills development in group settings. We may run specific training for those organisations when we see the same confusion or carelessness across plans, across staff, or over time. We educate by providing differential reinforcement to increase the compliance that we want to see, and we redirect to the non-compliance that we don't want. We monitor their progress over time to look for increases in the quality of their decision-making, their assessments, and their interventions. A few in the system are chances. They aren't compliant and they will take a chance in case no one is looking. Our response is enforcement. We are quick to provide quick and firm follow-up to extinguish the likelihood that providers will take a chance. We provide targeted audits of authorised program officers and organisations where there is evidence that the organisation is taking chances with statutory decisions. We work with our NDIS Commission colleagues and the Public Advocate to pull all of our levers for oversight as regulators and statutory officers. We revoke authorisation decisions made by APOs where the legal or practice thresholds have not been met. The Restrictive Practices Unit's enforcement approach to non-compliance by NDIS providers is a parallel process to your PBS approach when a person with disability does something that is unsafe. You would never allow unsafe behaviours just because someone is traumatised or has disability needs. In the same way, we would never condone non-compliance because an organisation is under pressure. We always respond. But we know that it's not the severity of this response that changes behaviours. It is the certainty of the response. It is about knowing that if you take a chance, you can reliably predict that the Restrictive Practices Unit will be picking up the phone and following up the issue with you. And we'll be firm and we'll be fair, but we will be very clear about what needs to occur to ensure that people are doing the right thing. Because ultimately, most people want to do the right things, and they will do the right things if it is easy to do and if they are supported to do so. On rare occasions, we may see egregious conduct. This is rare, but it does happen. And when it happens, we do not hesitate to provide clear sanctions. Since May 2022, 3 APOs have had their authorisations revoked. We do not make that decision lightly, but we do it because we know the standard that has been set for statutory decision making in the legislation, the regulations, and the guidelines. We know the standards that we hold APOs to and the standard that APOs hold themselves and each other to. Not all non-compliance is the same, in the same way that not all behaviours are the same. We know that the same behaviour, the same non-compliance, may have a very different function and a different origin depending on the behaviour, on the person or the organisation. We match the response to the profile of the behaviour in a parallel process to the way that you adapt interventions based on the function of the behaviour. Remember what I said about PBS being systematic and structured? It's not just about providing proportionate tiered supports based on the behaviour or the compliance. It is about the systems that enable those interventions. It's about the layers of data that you have to understand what is happening in the organisation. It is about the practices that you use on a daily basis. Our systems include the restrictive practices systems. Our dashboards and the dashboard that you see when you log on to RPS are designed to give you oversight of the restrictive practices for your organisation. The system makes sure that due dates are visible, prompts and alerts are provided, and reviews are very clear. Every working document that we use in the Restrictive Practices Unit is publicly available on our website. This goes beyond just having good legislation, guidelines and policies. This was a deliberate decision to be visible, accountable and transparent in the way that we do our work. Why? Because we want to be consistent and predictable. We know that if people know exactly how we make our decisions, the rules that we have to follow and how we will respond, they will engage with us. That's why our internal procedures for how we respond to appeals and complaints is publicly available. We want to remove the barriers to complaints. People feel safer to engage when they have predictability and consistency about how another person will respond. Our training schedule and audit schedule are informed by the RPS data and the trends that we see in behaviour support plans. We provide universal training to make sure that we are meeting the needs of the majority of the sector who are complying, and targeted training and enforcement to those who are not complying. So consider your systems in your organisations. Do you have the systems in place? Do they reflect your PBS approach to behaviour? The Restrictive Practices Authorisation Scheme is data informed. The RPS allows us to extract data at a client level about the number and types of restrictive practices. It documents longitudinal changes to restrictive practices as they are continued or discontinued over time. And if you're documenting your usage of RPs in the system, we can see this too. But we look at more than just client data. The RPS allows us to track APO level data. We can extract every APO decision by the number and types of RPs they authorise. We track the RPs that are endorsed by the APO, but that are subsequently not authorised by the RPU. In South Australia, APOs made the final authorisation decision in 16% of restrictive practices statewide. 84% of decisions are ultimately made by the RPU using the delegation of the SAO. But this is not the full picture because 47% of the RPs that are determined by the SAO are originally assessed and vetted by the APO. APOs are an essential part of the safety net. RPS can extract organisational level data for every NDIS provider in the system. How many RPs? What types? For whom? Where? We are trialling with some providers the sharing of their organisational data with them so that they can see the themes and trends that can inform their policies and practices. These trials are helping the RPU to increase data agency and the capacity of organisations to grow and use their data to strengthen their systems. So consider your own data in your organisation. What data do you have? What data do you need? How would you like us to support you to increase your data agency over your organisation's restrictive practices data? And finally, there are the practices that are fundamental to our systems-wide PBS approach to regulation. The practices that we undertake with implementing providers, APOs, professionals, family members are a parallel process to the trauma-informed positive behaviour supports that you use every day. We explicitly teach skills like you do. When you see a person with disability who doesn't know how to tolerate waiting, or how to ask for help, or how to take a break, you explicitly teach these skills. When we see an APO who may not be making good authorisation decisions, we explicitly teach the skills of making statutory decisions using legal and practice thresholds. We teach the skills of having a tough conversation within your organisation or with another organisation or with a legal guardian about a restrictive practice that may not be required. We teach the emotional regulation skills of how to name your discomfort with a practice or a strategy, or how to seek help to pursue a line of inquiry with a doctor, an OT or a physio. And like you, we understand the value of practicing the skill. We don't say, well, we told this provider that this is the rule and they're still not following. We know you have to practice it. We know how clunky it feels when you are first learning and how it gets easier with practice. Many professionals practice these skills with the restrictive practices unit through modelling, and it makes them better at their jobs. This is positive behaviour support. We provide differential reinforcement to increase the behaviours that we want to see and to extinguish the behaviours that we don't. This is why the people in this room and the sector receive emails and phone calls from us when we see a fabulous fade-out plan or a beautiful consultation with a person with disability or an excellent social story. If this was in a behaviour support plan, it would be called Catching You Being Good. It's also why you hear from us very quickly when you've done something you shouldn't have. In 2023, the median number of days between when an NDIS provider submits an RP request and when they receive an outcome is 2 calendar days. Since the commencement of the scheme, the median number of days has never been more than 5 calendar days. This is not just about the team being efficient, although they certainly are. This is about reducing the length of time between when you do a behaviour and when you receive reinforcement for that behaviour. We know that you're likely to change behaviours when we provide reinforcement very quickly afterwards. And we know that we are succeeding when providers and APOs contact us and let us know they've spotted a mistake that they've made and they ask for our help to fix it. This is a system that is learning how to move away from an external locus of control to building their own internal locus of control. It's moving away from the RPU needing to catch the mistake to providers catching their own mistakes. And finally, our practice as a regulator is fundamentally based on the relationship that we have with you. In the same way that you know a relationship of trust and respect is the foundation for any behaviour intervention that you do. Without question, the number one piece of feedback that we get from the sector is how much the sector values being able to contact the unit and speak to somebody who will try to help them. Many of you know the team well and may have had daily conversations with the team over the past 2 years. This is relationship-based practice. This is how we create a sector that has the capacity to grapple with the grey areas. If it was black and white, you would work it out already. If it could be read on our website, you would figure it out. Many of our duty calls are people who say, I've read the guidelines and I need help applying it to this situation because it doesn't quite fit. The ability to unpack the areas of grey is how we support a sector to be nuanced and to wrap responses around a person with disability rather than expecting people with disability to fit into our rules. Remember Sandra Bloom and trauma-informed organisations? There is a presumption sometimes that because we are skilled professionals in very important roles, that we just need rational language-based content by which we will make logical decisions by weighing up the pros and cons. And yet we know that professionals can be under immense stress because you're responding to another critical incident in a SIL, or you've got your audit coming up, or you've been debriefing with a staff member who's been injured at work, or you've been in hospital with a person with disabilities all night following their self-harm. When you are under that constant stress, parts of your brain shut down. You lose access to your language centres, your executive functioning. It doesn't look the way that it might for a person with disability, but it's a professional version of it. It might be being a little bit scatty and all over the place. It's about losing your train of thought and thinking a mile a minute and tripping over your words. That is why we provide the discussion. It's not just the content of our advice. We could email that to you, and we often do afterwards. When we are having the conversation, your mirror neurons and your spindle neurons are responding to the rhythm and the cadence and the specific decibel range of our human voice. Your limbic system is responding to the relational content long before your neocortex can respond to language and reason. People might be surprised that I'm describing a process of co-regulation that you and your staff do with clients. And here we are doing this with professionals. But anyone who's been following Fiona Kerr's research on neuro-leadership and how leaders change the brains of their staff knows that this parallel process is well established. We are standing on the shoulders of giants. We are applying a parallel process to professionals that you apply for people with disability. So consider the practices that you use in your organisation. Do they reflect positive behaviour support? Are they trauma-informed? Or are you only using these practices in your client work with people with disability? Do you use them within your organisation when you see cognitive rigidity or resistance? Do you use them with your interagency peers when you see siloing or conflicts or punitive responses? Do you use them to challenge learned helplessness or unproductive patterns of behaviour? Can you? The Restrictive Practices Scheme formally commenced on the 30th of May 2022. Almost 2 years down the track, we have established a solid foundation for a regulatory scheme that holds the system to the highest standards while recognising the power of high quality practices and relationships-based practice to change lives. This is a scheme that was created with our sector. It was created by the people who made submissions to the public consultations on the Act, the regulations and the guidelines. It was created by people with disability and their families at SACID, Our Voice and JFA Purple Orange, who shared with us what life looked like for them. It was created by behaviour support practitioners who sat down with the team to map business processes. It was created by the user acceptance group who tested the RPS and who tried to break it for us. It was created by the National Disability Services Safeguarding Community of Practice, who must have gotten sick of seeing us every few weeks for months on end. Our early adopters started registering on the system even before the legislation commenced. Our NDIS providers, APOs, practitioners and the NDIS Commission worked with us to develop the guidelines and continue to work with us to tweak the schedule to make it clearer and address those tricky situations that we may not have contemplated. Our colleagues in the Department for Child Protection and the Office of the Public Advocate worked with us to prioritise responses for children in state care and people under the guardianship of the Public Advocate. Our regulatory approach will continue to be shaped by the work that we do with you every day. When we discuss with you the work that you do to change and support behaviour at an individual level every day, we think about and plan what we want this to look like at an organisational level, at a state level, and with our state, territory and federal colleagues at a national level. We are dreaming in years about what we want to achieve for people with disability, a life and a community that is unrestrained and unrestricted. Thank you.